Hi, guys. Welcome back for our daily practice questions. It is day 214 and our Pharm series continues. But as always, I like to first start with my introduction and disclaimer before getting started with our questions for today. So, for those of you who are familiar with me, hey, y'all. For those of you who are new here, welcome, welcome, welcome. I am Dr. Brittany Weinstock, a family nurse practitioner and the founder and CEO of the Nursing Studio. I provide resources, tools, review courses, review videos, review books, digital flashcards, Q banks, one on one sessions, and more to assist nurses as well as nurse practitioners with success on their boards as well as in practice. I've been doing this since 2015, assisting nurses and nurse practitioners internationally with exam success. But y'all know my disclaimer and reminders that we know there's no absolutes in medicine. We treat on a patient by patient basis, and any of the questions that you see here, I have designed and created based on the current guidelines that are being tested on the ANCC as well as AANP exam. Now, any of my videos where I'm teaching on things that we currently do in practice, I will always say that so there's no confusion. So, with that being said, let's get into question number one for today. But before we get started, don't forget to hit the subscribe button so you're not missing any of my videos. And if you would like to gain access to my MP Test Success Toolkit, it is free and linked in the description. Also, my website is linked in the description and it houses all of the resources that I offer for first-time test takers as well as those who may be retesting. And you guys, if you're looking to join the upcoming 5-week intensive review, I have one space that still remains, and class runs from August the 11th through September the 12th. Through this 5 weeks, we navigate through all of the systems in preparation for the ANCC as well as AANP exam, and this is the answer to exam success. So if you're looking to join me, click the link in the description. All right, y'all, question number one. Question number one states, a 32-year-old woman presents with nasal congestion, facial pressure, and clear rhinorrhea for the past 5 days. She has no fever, her symptoms are improving, and she denies any significant facial pain. What is the most appropriate management? Is it A, supportive care only, being nasal saline and analgesics? Is it B, amoxicillin plus clavulanate? Is it C, oral prednisone? Or is it D, azithromycin? Take a moment and tell me what you got in the comments, y'all. All right, y'all know I always recommend reading the stem of the question first, as it allows you to slow down to ensure you're answering what is even being asked of you, right? So the stem of the question states, what is the most appropriate management? So this is a treatment question. And I tell you for treatment style questions, if the stem is looking for a treatment, you need to look and see if they provided you with a diagnosis. And if they have not, then you need to run it back a step further and look at those assessment findings. So here, there's no diagnosis provided, so we have to run it back and look at those assessment findings so that we can determine what it is, right? So we have a 32-year-old woman that came in with nasal congestion, facial pressure, and clear rhinorrhea for the past 5 days. Y'all, classic presentation for sinusitis, right? She doesn't have a fever. Her symptoms are getting better, and she denies any significant facial pain. But that facial pressure, that clear rhinorrhea, nasal congestion, classic for sinusitis, but this is viral. It's also only 5 days in duration and it's improving. So then let's take a look at the options. In this scenario, A would be your best answer, just supportive care like nasal saline and analgesics because it's viral. So no antibiotics needed. All right, question number 2. A 40-year-old male presents with purulent nasal discharge, facial pain, and pressure for 12 days with worsening symptoms. He has no known drug allergies. What is the first line treatment? Is it A, azithromycin? Is it B, augmentin? Is it C, levofloxacin? Or is it D, cefdinir? Take a moment and tell me what you got in the comments, y'all. All right, so stem of the question here states, what is the first line treatment? Again, we look to see if there's a diagnosis provided since this is a treatment question, right? And it's not, so you got to run it back and look at the assessment findings. So we have a 40-year-old male. He presents with purulent nasal discharge, facial pain, and pressure for 12 days with worsening symptoms, and no known drug allergies, right? All right, so the keys here is that this is purulent nasal discharge, facial pain. So still sinusitis, but that purulent discharge is making us think there's maybe a bacterial component. 12 days with worsening symptoms. Anytime you think sinusitis and it's 10 days or more, it warrants treatment with antibiotic management, okay? So 12 days also letting us know we need to implement therapy. Now the question you can ask yourself is, how do I treat first line bacterial sinusitis, right? And you should be able to tell me augmentin. So B is your best answer. Also remember how medications are listed in both names. So amoxicillin plus clavulanate, or it may say clavulanic acid, is augmentin, right? So B is your best answer. All right, and lastly, question number 3. A 28-year-old woman is diagnosed with acute bacterial sinusitis. She has a penicillin allergy that causes angioedema. What is the most appropriate antibiotic alternative? Is it A, amoxicillin? Is it B, doxycycline? Is it C, cephalexin? Or is it D, clindamycin alone? Take a moment and tell me what you got in the comments, y'all. All right, instead of the question here, what is the most appropriate antibiotic alternative? So again, this is a treatment question, but let's see what we're treating. And a diagnosis is provided in this scenario. So we are treating acute bacterial sinusitis. So then you want to walk through the steps when the diagnosis is here and see what else is provided for us. So we have acute bacterial sinusitis, and the patient has a penicillin allergy, right? And it's a severe penicillin allergy because it causes angioedema. So then you want to think about, how do you treat bacterial sinusitis? Now, you know, in the last question, our first line therapy is augmentin, but this patient has a severe penicillin allergy. So we don't want to give augmentin because it is made up of what? Amoxicillin plus clavulanic acid. Amoxicillin is a penicillin, right? So we know we couldn't go that route. We know we're not giving amoxicillin. And then you want to go with B, doxycycline, as your answer, simply because of the severe allergy to penicillin. So you don't even want to give those components of cephalosporins, because remember, penicillin and cephalosporins are cousins, they're sisters. So when you have a severe allergy, you don't want to give either or, okay? And then clindamycin is not how we treat bacterial sinusitis. So again, B, doxycycline is your best answer. All right, you guys, I hope you found this helpful. As always, be sure to like, comment, subscribe, and share with whoever you may think may find this beneficial as well. But y'all know what to do. Y'all make sure y'all meet me back here. And if you need any other resources that I do offer, feel free to reach out to the nursing studio by giving us a call at 803-400-6864. You can also shoot a text message to this number or shoot us an email to thenursingstudio1@gmail.com. Everything that I do offer is linked in the bio of this channel, including my website. And again, as I mentioned previously, my website is linked in the description of this video, and it houses all the resources that I offer. All right, y'all. Y'all know what to do. Y'all make sure y'all meet me back here. Happy studying. Bye, y'all.